Assalamu alaikum, everybody. I am Dr. Yusuf, and I welcome you all on behalf of PSSLD to this our regular weekly activity of General Club. Today, we are grateful to our honorable host, who is Dr. Michael Patrick Johnston, who is working as registrar in the Department of Gastroenterology, Glasgow Royal Infirmary, Glasgow. Today, he is going to present one of the paper which was recently published, and it is basically a randomized control trial. So we welcome Michael Patrick, and we are thankful to him on behalf of PSSLD and all other uh, all members who, and he has given us a time. So thank you, sir, and you can start the presentation.
Well, yes, thanks for letting me join your journal club this week, and particularly thanks to Nadeem Tahami, who is my previous boss at Southampton. So as you said, I work in Scotland in Glasgow Royal Infirmary as a resident or a registrar in gastroenterology and hepatology. And so I thought carefully about what might be a paper of interest for you all, and what might generate some conversation, and maybe learn about what the practice is in Pakistan for patients who are difficult to manage with esophageal hemorrhage, variceal hemorrhage. So I selected this paper that was published this year by a Scottish group, and anyway, we'll talk through it, and I hope there's some good conversation that comes from it. So I'll just share my screen. The individual who is hosting, are you able to enable sharing screen?
Yeah, you can. Yeah. We can hear you, sir.
So as I said, so this is a paper that was published just recently in APT, and it was a randomized clinical trial, a standard of care versus early tips in patients with cirrhosis and esophageal variceal bleeding. And I have no disclosures, and as I said at the onset, it's really predominantly European data, so it would be interesting to hear what the practice is in Pakistan, for example, for these patients. The background to all of this is, as I'm sure you're aware, is that this appears to be a slightly controversial topic of early tips, less than 72 hours, for acute esophageal variceal hemorrhage. There's historical evidence of a clinical benefit of early tips versus standard care. Going back about 16, 17 years, it was found that in high-risk patients, if you stratified them by hepatic venous portal gradient, that there was a survival benefit or a rebleeding benefit. And if their pressure was greater than, or their gradient was greater than 20 millimeters of mercury. Certainly in the United Kingdom and a lot of centers in Europe and elsewhere, it wouldn't be standard, and it's not that clinically convenient to be measuring portal gradient. And so a subsequent study, which used Child-Pugh as a risk stratification, was a little bit more relevant to real-world practice. And that was a bit of a seminal paper in 2010, which enrolled patients with either Child-Pugh B, 7 to 9 points, or Child-Pugh C, 10 to 13 points. And it was seminal in it demonstrated that there was a rebleeding benefit if you inserted a TIPS within 72 hours of index endoscopy. It was a randomized controlled trial in a tertiary center in Spain. It was conducted over 3 years. Inclusion criteria, as I described, and there were 31 of 32 patients in the two arms, so not a large study. Nonetheless, it appeared to be powered to find a difference in its primary endpoint, which was a composite of either failure to control bleeding or prevent rebleeding in 1 year. And you can see that the difference was quite stark. So rebleeding in 1 year in standard of care was 45% versus early tips, only 3%. what they interestingly also found was a secondary endpoint was survival. And there was a statistically significant benefit of early tips, both for short-term survival, 6 weeks, and also 1 year survival. So 67% versus 90% for 6 weeks, and 1 year survival, standard of care 61% versus 86%. So quite a difference. And the impact of that paper has been fairly large. Wasn't replicated for some time, but it has been subsequently incorporated into a number of international guidelines. Now, I work in the United Kingdom, currently in Scotland, and the British Society of Gastroenterology in 2015 published its variceal hemorrhage guideline. And it recommends after satisfactory hemostasis with the methods above, those being band ligation, and depending on resources, early covered tips less than 72 hours after index variceal bleed can be performed in selected patients with child's B cirrhosis and active bleeding, or child C cirrhosis with a child score less than 14. So certainly not prescriptive that this should be taking place, and I suppose a little bit ambiguous on which patients with that you should be considering it. EASL, the European body, also suggests it. It doesn't make a firm recommendation, but similarly suggests based on that previous paper. But it's quick to point out that it remains debatable and needs further study. So since in the last 10 years, we've been in a position where this may be a treatment that's beneficial, it's suggested in guidelines, but is it implemented? Well, a couple of years ago, again in Europe, so a large multi-center audit in France looked at academic and non-academic centers, and of a study population of over 900 patients, those eligible for an early tips, going by the criteria in those guidelines described, were over 300. How many went for an early tips? Only 22, so only 7%. So it seems fairly clear that people aren't convinced by this, or logistically it's very difficult to carry out. So there are a number of questions, and I imagine that these are questions that are international, but particularly in the UK. Does early tips need to be considered more routinely? Do services need to be restructured to support early tips? But before answering these questions, can the association between TWIPs and better outcomes be replicated in another centre? So the paper that I've decided to discuss is the Scottish experience of that, and in trying to answer that question. And it was published in AP&T this year by colleagues in Glasgow Royal Infirmary, one of my registrar colleagues, Philip Dunn, and the senior investigator was Peter Hayes in Edinburgh Royal Infirmary. So standard of care versus early tips in patients with cirrhosis and esophageal variceal bleeding. So it was in those two centres, which are both two of the largest centres in Scotland, one of which is a liver transplant unit, both with a 24-hour tip service. And you can see it took some time to recruit all the patients and carry out this study, 6 years from 2012 to 2018. The inclusion criteria: liver cirrhosis presenting with acute esophageal variceal bleeding, so esophageal, and subsequent hemostasis with treatment by vasoactive drugs and EBL, endoscopic band ligation. Exclusion criteria were very similar to that previous New England Journal paper in 2010. So age less than 18 or over 75, pregnancy, child PU out with the described range, so less than 8 or greater than 13. Inability to control bleeding at the index endoscopy, previous tips, previous pharmacotherapy and banding, known portal vein thrombosis, gastric or ectopic variceal bleeding, active cancer, or recurrent admissions with hepatic encephalopathy. So very similar inclusion-exclusion criteria to the previous paper. Patients were randomized after achieving hemostasis in a one-to-one fashion to either standard of care or early tips. And that was performed in a robust way by a 24-hour web-based randomization system. The study procedures, so pre-endoscopic treatment included terlipressin, 2 milligrams 4 times a day, and antibiotics. And that's really standard of care in the United Kingdom and as per our national guidelines. Ligation was performed to gain hemostasis if actively bleeding varices, or to treat pre-existing varices which had high-risk stigmata, such as fibrin plug or whale sign. I thought it would be helpful to point out, as we go through this, any differences with the previous paper. So one marked difference is that in the Spanish study, there was a mix of band ligation and sclerotherapy. In fact, about a quarter of patients were treated with sclerotherapy in the older paper, which I suppose reflects more common practice at that time. Certainly in the United Kingdom, since 2010 and more recently, it would be rare for sclerotherapy to be used, and the first line recommended treatment is band ligation. Similarly, the use of vasoactive drugs in that previous study was a bit more heterogeneous. There was a mix of terlipressin, somatostatin, or octreotide. Really, terlipressin is mainly used in the UK. So the standard of care after randomization was to continue terlipressin at the same prescribed dose for up to 5 days. Antibiotics continued for 5 to 7 days, and subsequent entry to a variceal banding program at 2 to 4 weekly intervals. Carvedilol 6.25 milligrams was commenced discharge and dose titrated as tolerated by the patient. Early tips, terlipressin was continued until the tips was performed. Antibiotics continued for 5 to 7 days. They were covered stents, initially dilated to 8 to 9 millimeters. If their portal pressure failed to fall below 12 millimeters of mercury, then the stent was dilated to 9 to 10 millimeters. And then patency was checked at 6 months and 1 year, either by tipsogram or an ultrasound. And so all patients in both arms had follow-up at 6 weeks, 6 months, and 1 year. And the outcomes that the Scottish group were looking to assess were survival at 1 year as the primary outcome. So different to the 2010 study, in which the primary outcome was rebleeding, but a secondary outcome had shown an improvement in survival. The primary outcome in this study was survival. But clearly, their interest in secondary outcomes of short-term survival and rate of early bleeding and rate of late rebleeding. And they used the same definition of rebleeding as per Bovino, and needing 2 units or more of blood transfused or repeat endoscopy as the original study. So a slight difference there, but not too much really. And statistical analysis of the study aimed to confirm the results of the first early tips randomized controlled trial we discussed earlier on. Now, in terms of power, they calculated that 48 patients per group were needed to find a difference in survival between the 2 arms to give an alpha of 0.05 and a power of 80%. And they aimed to carry out an intention to treat analysis, followed by per protocol analysis. So the results. So 206 patients admitted and screened. Ultimately, 59 underwent randomization, 1 withdrew consent. So 29 were assigned to both arms. So you can see that that was less patients recruited than aimed for in terms of powering the study. So the authors clearly make reference to this in the discussion, and the fact that it was underpowered. In terms of the patient characteristics of the 2 groups that they recruited, They were well matched, and for the most part, they were similar to previous study. Predominantly alcohol as the etiology of liver cirrhosis. There was a similar proportion of child C and child B patients. There's also similar distribution in terms of their serum bilirubin and their ascites. One main difference I noted was that active alcoholism was higher in this Scottish paper than in the previous New England Journal paper. And to those of you who might be familiar with prevalence of liver disease in Europe or the United Kingdom, there's a particularly high prevalence of alcohol-related dependence or alcohol-dependent syndromes and alcohol-related liver disease in Scotland, particularly the west of Scotland where I work in Glasgow, but across Scotland, even compared to the rest of the United Kingdom. So it's not surprising that there may be a greater degree of active alcoholism. That's interesting because whether it has potential to affect long-term outcomes is possible. So the results in the standard of care arm, so 21 patients maintained on a beta blocker. 14 out of 29 participants had varices eradicated. 15 of 29 not eradicated, either because they had multiple sessions and they were not eradicated even after multiple sessions, or they rebled needing a rescue TIPS, they died, or they refused to have endoscopy. In the early TIPS arm, so 23 of the 29 received shunt placement. Actually, 10 of those received a shunt outside of 72 hours. 3 of the patients had a portal pressure that remained greater than 12. The 6 who did not undergo shunt placement at all was due to logistical or practical issues. And I think that the caveat at the start of this was how long the trial took to carry out. So it took 6 years, and knowing a couple of the investigators, it was logistically a very difficult study to carry out. For example, in patients who would present on a Friday, to then randomize them, particularly if they present on a Friday night, to randomize them and organize a TIPS within 72 hours was very challenging. So unfortunately in that arm, even 6 of them did not undergo shunt placement. Those patients had standard of care, therefore they had entered a banding program and really went into standard of care description. So the main result, the primary outcome, 1 year survival, there was no significant difference. You can see that the survival at 1 year was 75.9 versus 79.3%. The first being standard of care and second being early TIPS. And a p-value of 0.79. So in contrast to that previous study, there was no benefit in terms of 1 year survival. What is notable about those figures, and which the author is keen to discuss, is that the survival with standard of care in the previous study was notably lower at 61%. And it's interesting to speculate about whether that is reflective of the slightly different standard of care using older modalities such as sclerotherapy. They can't be directly compared, clearly, because they're not matched populations, but it is interesting to note that it does seem to be lower, the survival in the standard of care previously, and whether that accounts for the difference previously and with better standard of care now, maybe that accounts for some of the difference. Secondary outcomes, so early rebleeding, 0 to 6 weeks, standard of care, 17.2% versus early TIPS, 3.4%. And although the authors say that there was no difference in early rebleeding because the p-value was 0.08. I think it's relatively clear that there was a difference. I think the difference between the p-value of 0.05 and 0.08 is pretty minimal. And we've said that they under-recruited. So I don't think I think they found the same as the previous study. Later rebleeding, standard of care versus early tips, 17.2% and 20.7%. There was no convincing difference, although variceal bleeding was similar to early rebleeding. So all early rebleeding was variceal. What is interesting though then is if you look at the per protocol analysis. So 1 year survival standard of care, 75.9% versus 76.9%. So again, there was no difference when you perform per protocol analysis. So not an intention to treat analysis, just looking at the patients that underwent the procedure. So who underwent band ligation or who underwent an actual TIPS within 72 hours. Again, though, the caveat to that is that the numbers were particularly small in the early TIPS, so only 13 patients. In terms of secondary outcomes being rebleeding, so there was a clear benefit. So if you underwent an early TIPS compared to standard of care, there was a definite significant difference. And even if you're quibbling over p-values, it was less than 0.05. Interestingly, the previous paper in 2010 found no significant difference in hepatic encephalopathy, which is contrary to what you might worry about for patients undergoing TIPS. In the per protocol analysis in the Scottish paper, they found that there was a difference, and it was, as you might expect, slightly more. So standard of care, about 20% hepatic encephalopathy, and I think that is over 1 year compared to 46% if you had early TIPS. The only thing that they, having looked at the protocol, the study protocol, and reading through the method, it's not exactly described how hepatic encephalopathy was defined. It was just defined as hepatic encephalopathy. In the patient characteristics, they're careful to describe it as either grade 1 to 2 or grade 3 to 4. But in terms of measuring adverse events, they're not as refined in terms of how it's described. So whether there is a slight potential for measurement bias or even recall bias with that, people undergoing TIPS were told that it was a risk factor for developing encephalopathy, or family were told. And they were then obviously not the staff and the researchers were not blinded to what procedure they had. They knew that they'd had a TIPS. So it would be potential to look for encephalopathy more. There wasn't any objective measures, as in doing a cognition test or formal looking for apraxia or describing it as West Haven criteria 1, 2, 3, 4. So I think that probably that's probably not that important, and you would expect that people who had a TIPS had more encephalopathy. However, it would probably be helpful if it had been very clearly objectively measured. And for example, if all of the patients actually were just had grade 1 encephalopathy or minimal hepatic encephalopathy, that increased rate of encephalopathy might not be quite as worrying. Anyway, a minor point. So what did the authors say? Well, so they said, in contrast to previous work, our findings do not support use of early TIPS placement for the improvement of survival in cirrhotic following esophageal variceal bleeding. Our 1 year survival rate of 75.9% in the standard of care group is much superior to the 61% reported in the previous study, which likely explains the difference in statistically significant survival outcomes between the two studies. So as mentioned before, the standard of care was different. Although there were no differences in rates of rebleeding observed on an intention to treat analysis, we do report significantly reduced rates of variceal rebleeding for those receiving early tips on a per protocol analysis, as well as an analysis of all participants who received tips placement. I've just highlighted that although they've said there are no differences in rates of rebleeding, I think that in a trial that didn't have very many patients and had a p-value of 0.08, that's highly debatable. I think there was a difference in the intention to treat analysis. Furthermore, the population studied was predominantly alcohol-related liver disease with ongoing alcohol consumption, and this has obvious implications on long-term survival. And I suppose we need to think carefully about whether that's a potential confounder. So in the Scottish cohort, the fact that there was a lot of active alcoholism, potentially the long-term benefit of tips is arguable. And really, if you have ongoing drinking, that is still going to be the greatest predictor of your more long-term mortality. So quibbling over your 1 year survival when you're still actively drinking might be a bit academic. But I don't think that made a massive difference. I think, although it's not described, there wasn't a great deal of difference in how they presented subsequently in the following year. And mainly I'm just basing that on looking at, for example, did many present with alcoholic hepatitis, and there wasn't much of a difference. So in terms of what the adverse events were and what the causes of deaths were, I'm not sure if that had too much of an effect, really. And ultimately, this is a real world study, and in the United Kingdom, there's high prevalence of alcohol intake, so it is relevant to our population. The author's conclusion. So our underpowered study shows that placement of early tips appears to reduce rates of variceal rebleeding, but increases rates of hepatic encephalopathy with no effect on survival in patients who have Child-Pugh B and Child-Pugh C. And I think that's a fair conclusion. And they make the recommendation for further randomized controlled trials. So before opening it up to what other people think of this paper or the topic of early tips in general, my thoughts were going through a critical appraisal of the study. Patients were assigned to treatments by a robust randomized method. The patient groups were well matched. All the patients were accounted for, and an intention to treat analysis was performed. Although it was disappointing that a considerable number of participants in the early tips arm essentially underwent standard of care. So 6 of the patients didn't have a tips, and they had standard of care treatment. And that arguably introduces misclassification bias. And anytime you have that, I suppose you're probably going to be more likely to accept the null. In this case, no difference in survival. The measures they used were objective, rebleeding definitions or death. Hepatic encephalopathy is broad, though, and unclear how this was measured. Was it by admissions or grading? And possible measurement bias if this was not considered. However, I think that the finding that there was more encephalopathy in people who underwent TIPS is in keeping with previous literature and what we would really expect. And I think there was a lot of, it was a surprising result in the previous paper that there was no difference in encephalopathy between the TIPS and standard of care arms. I think where this paper, although it has some methodological flaws, and particularly its underpowering, where it has a lot of strength, and we've learned a great deal, is its external validity and applicability. So despite the underpowered nature, it is applicable to real world practice, and it's very applicable to practice in the United Kingdom and particularly Scotland. it replicates 2010 data that early tips is superior to standard of care in terms of rebleeding risk. I don't think there's much argument about that. There probably still is an argument about what survival benefit there is. Although this study does demonstrate survival benefit, it remains unclear whether this is, although it does not demonstrate a survival benefit, it's unclear whether it's due to being underpowered or whether a standard of care has improved, I suppose, internationally. So I'll invite anyone else on the side to comment or ask questions or propose their own thoughts on this paper or tips that been used early, and also take the opportunity to say thank you very much to Nadeem Tahami for inviting me to join today.
Thank you, Michael, for presenting such an interesting topic. Yes, we have many senior faculty with us who are here. We will take their opinion one by one, and we will take Dr. Nadeem Tahami opinion as well. Here, I'm going to unmute Professor Yasun Nabi Tayyab. He is having some valuable comment. We'll take his opinion first. Sir, I am unmuting you.
Hello, everybody. Can you hear me?
Yes, sir, we can hear you.
Yeah, this is Khalid Mumtaz. So, interesting study, and thank you for the presentation. I have a few comments. As he has already elaborated, that it was an underpowered study, and it seemed that they were unable to achieve any difference in the primary outcomes, that is survival at 1 year. And what they have achieved is just lesser early rebleed at the cost of 46% hepatic encephalopathy, which is something very difficult to sell and get published in APNT. So I'm just thinking from the US standpoint that on the first admission with the variceal bleeding, if I offer somebody a TIPS procedure, I don't think that I'll be able to even convince myself to go for a TIPS for the first bleeding within 72 hours, which may be actually controlled with the help of endoscopic band ligation. So I'm not sure what is the practice in UK and currently in Pakistan about early variceal bleeding and taking the patient to the TIPS arm.
So I think that anecdotally in the United Kingdom, this is not really performed. And the best data I've seen is from that large French audit, which demonstrates that it's not really being done. Anecdotally in Scotland, it's not done a lot. And I think the greatest barrier is the logistical barrier of organizing with an interventional radiologist within 72 hours for a patient who's achieved hemostasis, a complex procedure such as TIPS. I don't know whether Nadeem Tahami would comment on sort of similar experience.
But I'm myself, are you convinced that you are going to offer your patient TIPS when they are presenting for the first time with the variceal bleeding, where there are 90% chances that you will be able to control it with the help of band ligation? This is the biggest question that I have in my mind.
No, I mean, I don't. And that's what so anecdotally, I think that this is incorporated and suggested in guidelines, but no one really seems a lot of people don't seem to believe that it is a feasible procedure or that it is in fact beneficial.
Correct. It is an invasive procedure, and if you look at the paper from 2010 in NEGM, they actually go for early TIPS in those who have rebled, which is very, very reasonable, which is standard of practice here at Ohio State University in USA and in many medical centers in USA as well.
So I will endorse what you've said. I think both of you, I completely agree. Everything you've just mentioned. I think obviously for the logistical reason, in majority of centers, it's not possible. I mean, as Michael knows very well, the TIPS service that we have is only between the working hours. So we do not offer it out of hours. And I think rightly so, because if you have an endoscopic modality available to treat it, and in patients who then rebleed are probably the right patient to be treated. Having said this, I think if you, it's probably in our practice all over the world, I'm not sure that if we measure the portal pressure as a standard of care, and we believe these patients have clinically significant portal hypertension because they have signs of portal hypertension. In majority of cases, when you're sort of banding or injecting the varices, I think what we're doing is we're just sort of covering the tip of an iceberg. So the underlying pathology of underlying portal hypertension is still there, especially in cases if they continue to have an insult to liver. So that could be somebody who has an untreated viral hepatitis, somebody who has metabolic risk factors with steatohepatitis, or somebody who's drinking actively. So in those cases, although indicatively, obviously, when these patients present, so I guess we get more involved with their care. So to some extent, we support their portal hypertension otherwise. But if the underlying etiology is still there, then I think it's important to sort of think of the best way of controlling portal hypertension. So in some ways, the previous study does make a sense, and I think I fully agree with the conclusion of this one as well. And I would say thank you, Michael, for doing an excellent presentation.
Hello, this is Saeed Hamid from the Aga Khan University. First of all, thank you for the presentation and taking the trouble to go through this paper so critically. Quite enjoyable. I have just a couple of observations and questions. I'm sorry I have not been able to read the full paper. Were there any quality of life data that was collected in both the groups? So that is an important question, I think. And the other one would be, what about should studies like this be accompanied with a cost effectiveness analysis? For example, were there lesser admissions or more admissions to hospital with hepatic encephalopathy who had a TIPS, although they rebled less in the first year and perhaps significantly so? But was there an overall cost effectiveness that was built into the study or not? Just one other small point, if you could answer, and that is, if you look at the Kaplan-Meier curves, the TIPS arm seems to be doing a little bit badly in the initial stages, and then it goes back up, and so the survival kind of improves. Would you like to comment on that as well? Thank you.
Yeah, I don't think, well, no, there weren't any quality of life measurements made. I think that in the same way with how incident hepatic encephalopathy was measured or defined, that would have been quite interesting to know what grade of encephalopathy did people have, how did it affect their quality of life, how did it affect in terms of admissions, because as a lot of people have already pointed out, 46% hepatic encephalopathy seems quite high, and that could have huge implications for quality of life post-procedurally. So I think that would have been helpful to know, and similarly that would have implications on the cost benefit. So I think it was too small figures for that. And in terms of scrutinizing the Kaplan-Meier curve, that's interesting. I hadn't noted that, although I suppose there's quite small numbers, and that is a difficulty with interpreting the Kaplan-Meiers. But that was my opinion. But
we have Professor Altaf Alam. Sir, you are unmuted. Your valuable comment, sir.
Thank you very much. Thanks, Michael. The debate goes on about the role of early preemptive tips in the management of variceal bleeding. And, it's a very healthy debate. There is emerging data on this issue. In Pakistan, our job is very simple. One, non-availability of round-the-clock interventional radiologists to do the procedure. Two, the cost of the procedure around £2,500, which patients pay from their own pockets. And I think with, as you mentioned, with, over a period of time, the improvement in the band ligation rather than sclerotherapy, and also effective control of gastric variceal bleeding through intervention has really made our job easy, that we are asking for less and less tips in this country. It would be interesting to have an IR, interventional radiologist view from Pakistan as well. And I think we have somebody on the forum. So Shah Yusuf, if you could have the opinion of our interventional radiologist. Thank you very much, Michael, once again.
Thank you, sir. Sir, yes, sir, we are having Professor Najmuddin, who is interventional radiologist. Sir, I'm unmuting you. You are unmuted, sir, Professor Najmuddin.
Yeah, thank you for giving me time here. I actually missed the earlier part of the talk, so I'm not aware of the actual contents of the talk, except I got in pretty close to the conclusion. But I recall talking about tips in Pakistan and how we have progressed in the last decade or so, and I've actually done a bit of audit as well, highlighting the number of patients each year which are undergoing TIPS procedure. So on average, we were not doing anything more than 30 odd patients per year across Pakistan, different centers. And the reason, as most of you have already highlighted, the first of all, the reason for not opting for TIPS was the cost factor. Clearly, that was at the top of the list. Secondly, we all IR people thought that, again, we did not have a true definition of early TIPS intervention in cases with variceal bleeds. Was it second or third? So, I kind of reviewed the literature, and this was the recommendations from most of the societies across the globe were aiming to doing TIPS after the second bleed and not delaying it further. But obviously, as highlighted by somebody, in our subset of patients, probably it's quality of life. If the endpoint would have shifted from overall survival, then probably we would be able to convince our patient subsets to undergo this procedure. But if you tell them that the overall survival is more or less the same, given the comparable management plan which the hepatologist is going to offer, then obviously then the choice goes out the window. So, there are a number of things. If you are truthfully kind of consenting the patient for TIPS, you do not leave much room to the patients and the attendants to spend that volume of, amount of money to get relief for a short-term advantage. And that's the reason we probably, our numbers are very, very low. And they wax and wane between 12 to 30. If you were to look at the figures in the last 5 years. The availability across Pakistan is also a limitation. So, bigger centers, tertiary care centers who are working with liver primarily and have backups and have clinicians who are tilted toward TIPS. These are the places where it's being offered mostly, but not in other general hospitals. So there are only a few hospitals which would offer such services, leave alone offering this service in the middle of the night. Even as an elective procedure, there are very limited number of places which would offer this procedure. So yes, there are a lot of things which we take into account in our working environment, but TIPS is going to remain a limited procedure for all our patients in Pakistan. And if your paper was to be taken into account by most of our patients, they would agree with you. They would probably opt not to get a TIPS done. So selling it is very, very difficult. Thank you. Thank you much.
Thank you, Professor Najam, for your valuable comment. Dr. Najeem Hami, you are unmuted, sir. Your comments, please.
Thanks, Yusuf. Michael, just one quick comment. I guess the patients in the tips arm all had sort of standard tips, because I'm sure you know there's a data out there, because there has been shift from uncovered to the covered tips, which obviously has improved the tips patency. But the risks of hepatic encephalopathy has clearly increased with the tips, covered trips. And I guess obviously there are recommendations out there in terms of how much pressure do you want to really drop post tip insertion, and I guess that would have been same in these tips across the group cohort.
Yeah, so I think that all of them had covered tips, as you said, and only one failed to have a drop below 12 millimeters of mercury. I can't remember if any, might have been one or two needed their stents reduced subsequently because of encephalopathy, because conservative measures didn't work.
If anybody has any question, they should raise hand so that we can take their question. Professor Zagham Abbas is here, sir. Your valuable input and comments, please.
Thank you, Michael. Excellent presentation. Impressed by the comparative study that you have done with the New England Journal of Medicine paper. That paper was published 1 decade before. So there's a lot of improvement in the standard of care, I suppose. And this has made the difference, because if you see their groups that receive standard of care, there was very much heterogeneity. Like some of the patients received metostatin, some of the patients octreotide or vasopressin. Some of the patients were given sclerotherapy versus band ligation. So now, like in this paper, the Scottish study, we in Pakistan use the same almost things like what we are using terlipressin, we are doing band ligation every 2 to 4 weeks. So I think that there is improvement in standard of care, and this may be the reason that there is no difference in the survival. Another thing is the under part, like you have rightly mentioned, the New England Journal of Medicine study had 63 patients, and this study had reported 58 patients. And out of these 58 patients, there was much violation of the protocol. As you rightly mentioned, and you compared this data, that 10 out of 23 patients received tips outside the 72 hours. That was a big violation of the protocol, and 6 patients did not receive shunt at all. Again, there was much violation of the protocol, but there was decrease in the rebleeding, and in the per protocol analysis, you rightly mentioned that the tips has got some edge over the standard of care, but the survival, I think the improvement in survival is because of the improvement in the standard of care. And in Pakistan, like previously mentioned, the cost is also important issue, and the quality of life, which becomes more deteriorated, I would say, by the TIPS procedure, because the encephalopathy, and that many of these patients who are in child C, already in child C class, and if you put TIPS and if you increase the diameter by dilatation more to 10 millimeter or more, then the risk of encephalopathy further increases. So these are the things that TIPS has become not so much popular, and the standard of care is still being followed. Thank you very much.
Thank you, sir. I can't see any further hand raised or any question. So I would like to conclude the session then. I am thankful to Dr. Michael for such a detailed and elaborate presentation. At the same time, I am very much thankful to Dr. Nadeem Tihami for his continuous efforts and making this journal club a good and continuous activity. I am thankful to all the participants and all our faculty teachers who put their input. I am thankful to the PSSLD President, Professor Zagham Abbas, and I am thankful to all the support team for maintaining this activity. We'll see you all next week, inshallah. Thank you very much.